All right, thank you, Chairman. Good afternoon, ladies and gentlemen. It is really my honor and pleasure to be here today. And first of all, I'd like to thank the organizing committee for giving me this opportunity to share my experience in HIFU treatment. My topic today is ovarian reserve after HIFU for ultrasound fibroid and adenomyosis, which is a little different from the one printed in your program because I think this is more relevant to fertility preservation. This is the summary of my presentation. First of all, I'd like to declare that I have no financial connection with any company that manufacture HIFU machines, and this is very important. I'm going to go through the development of HIFU in Hong Kong, some issues on ovarian reserve, and a brief discussion on fertility and pregnancy outcomes after HIFU. I started HIFU treatment for uterine fibroids and adenomyosis in 2012. Initially, we started as a research project, and up to around 2016, we do it as a clinical service. We are still using the HIFU JC machine since 2006. This is a very old machine. The resolution is actually not that good. A lot of artifacts. And fortunately, starting next year, we are going to have the new JC 300 machine, which we hope that we are all excited to wait for that to come and look forward to use this machine. This is a report of our preliminary experience of our initial 20 cases. You can see that most of our patients have a reduction in fibroid volume after HIFU treatment in the range of about reduced in the range of about 40% reduction to some of them are close to 100% reduction in fibroid volume. Similarly, most patients have an improvement in Similarly, most patients have an improvement in symptomatology, and as you can see, this is the symptom severity scores, which most of them shows a reduction in the scores. We are always excited when we see good responders, and this is one of the examples. This woman has a fibroid of about 6 to 7 centimeters in size before the treatment, and after that, the fibroid was about 2 to 3 centimeters in size. And you can see that we talk about it, this submucosal fibroid, and if you need to, we can easily deal with it with hysteroscopic resection. For adenomyosis, we also have our case series. Again, you can see that most patients have a reduction in menstrual pain scores in the range of a reduction of 40 to 50% menstrual pain score within 3 to 6 months after treatment. Again, for symptom severity scores, most patients have a reduction of the symptom scores of about 50 to 40%, 40 to 50% reduction in the symptom severity scores. Again, an exciting case to see that this woman has have adenomyosis in the posterior wall, and after HIFU treatment in 6 months, the MRI shows a well-defined ablated area of the adenomyotic area. When I first started to do HIFU treatment, I have some concern with the HIFU in relation to the ovarian reserve. And the hypothesis is when therapeutic ultrasound waves travel between the transducer and the target, thermal effect of HIFU may adversely affect the ovarian function if one or both ovaries are located along or alongside the course of sonication. For that, we'll talk about a little bit about ovarian reserve. It is defined as the number of oocytes remaining in the ovaries or the ovarian or the oocyte numbers, according to the American Society for Reproductive Medicine. Measures of ovarian reserve include basal serum FSH and E2, inhibin B, anti-malarian hormone, clomiphene citrate challenge test, ovarian volume, or follicle count. According to the American Society for Reproductive Medicine, currently AMH and AFC are the most sensitive and reliable markers of ovarian reserve. For AMH, it remains relatively constant within and between menstrual cycles, so you can take the AMH anytime during a menstrual cycle. Different from FSH and LH, you have to do it in early follicular phase. It's a more sensitive measure of ovarian reserve than FSH and tends to decline before FSH rises. And therefore, AMH has largely replaced basal FSH and E2 level as a marker of ovarian reserve. When I first started HIFU treatment, I do AMH level in patients before HIFU treatment and in 1 month, 3 months, and 6 months, and 12 months after HIFU treatment. And I find there was no difference between the AMH level before or any time after the treatment. Also, there was no patients becomes amenorrheic or reported symptoms suggestive of menopause. And this study was reported in April 2016. Our conclusion is that our experience suggested that ovarian reserve does not seem to be affected by ultrasound-guided HIFU in the treatment of uterine fibroids. However, our study has limitations. First of all, the sample size is very small. All of patients were over 40, as we do it as a research study, and potentially these patients are perimenopausal and they have low baseline AMH level. And whether this finding applies to younger women of reproductive age requires further evaluation. And also the duration of follow-up was only 12 months. More than a year later, there's another paper published in the BJOG on 79 patients. They do AMH before and 6 months after HIFU. And again, they show no significant difference in AMH level between the 2 time points. So their conclusions is ultrasound-guided HIFU ablation for uterine fibroid and adenomyosis was effective without affecting ovarian reserve. Following that, and more recently, there are other studies which also look at this on HIFU and ovarian reserve or ovarian function. I won't go through each of them, but in fact, if you see that most of them are using AMH as the marker. One of them is for cesarean scar pregnancy, and one of them is using MR-guided HIFU. And in fact, the conclusion for all of them shows that there's no difference in ovarian reserve before and after treatment. So in fact, all these studies basically confirm my initial finding of ovarian reserve does not seem to be affected by ultrasound-guided HIFU in the treatment of uterine fibroids and probably in adenomyosis as well. As we all know, ovarian reserve is not equivalent to fertility and pregnancy outcomes. We listen a lot about fertility and pregnancy outcome in these meetings. In fact, there are lots of case reports and case series on that. There are prospective and retrospective cohort studies. There are comparative studies or meta-analysis, but RCTs are lacking. So let's look at a few comparative studies. This one compare HIFU, myomectomy, and UAE, and they concluded that HIFU, especially ultrasound-guided HIFU, may be an alternative fertility-sparing modality for patients with uterine fibroids. For adenomyosis, they compare patients treated with HIFU and patients with laparoscopic excision. And they concluded that HIFU showed a safe and effective profile as a therapeutic option for patients with adenomyosis. In comparison with laparoscopic excision, HIFU treatment achieved better postoperative reproductive outcomes. There's also a systematic review and meta-analysis recently. They analyzed 25 eligible original articles for live birth rate in patients who had UAE, ultrasound-guided HIFU, MR-guided HIFU, and transvagal radioactive ablation. And they concluded that these uterine-sparing treatment options for uterine fibroids are good approaches for women wishing to preserve their fertility with comparable reproductive and obstetrical outcomes. So in summary, HIFU, especially ultrasound-guided HIFU, does not seem to affect or may even improve pregnancy rates for women with fibroids and adenomyosis, and therefore an acceptable alternative fertility-sparing modality for patients with these conditions. Pregnancy after HIFU appears non-inferior to outcomes after the current standard of care, but ultrasound-guided HIFU seems to be associated with a higher rate of placental abnormalities in some of the case studies. Further studies, including RCTs, comparing HIFU with other treatment options on long-term reproductive outcomes will be needed. Thank you very much for your attention. 谢谢大家。
Thank you.
的一个生殖能力来说。